examined, and the cervix at 1 p.m. was found to be 2 centimeters dilated, posterior, presenting part of -2. CTG was done, and this is her initial CTG. However, again, she was given the option and she decided to go back home again. So this is, mind you, this is the third presentation, and this is her initial CTG. So we know that the baseline was around 135 to 140 before from auscultation with documentation. And this is her baseline CTG. Would anyone like to comment on it? Is this baby fit for labor? Are we all happy with it? Anyone?
My question, Maya, is not only is she fit for labor. My question is, how is she sent home with this CTG?
That I couldn't find documentation, to be honest, on, but also I think when someone has been coming every couple of hours, even without CTG, we have to question what's going on with this lady. So yes, I completely agree that so the baseline is still at what we think is the same, but the variability is markedly reduced at this strip of the CTG. So we can notice that she is contracting 4 in 10, but the variability is significantly reduced in this. So what would we do? Anyone?
And also the deceleration.
I just have.
Say again.
Sorry, I just have a question based on what Ms. Naguib said, because I missed the earlier bit of the CTG class. Did she get sent home with this CTG? This is the CTG and she got sent home?
No, so this is the third CTG. This is a paranot who came in with SHROM. So she's termed SHROM, and she SHROMed at 2:30 a.m. They've done a CTG which we could not find, but the documentation was that it was normal. And then she was sent home, came back again a few hours later, found to be contracting, and this is her third presentation. So this is the third time she came in with SHROM, early labor, and this is the only actually strip we have. This is the first time like we have a CTG for this laborer.
Okay, thank you.
Yeah, so what would you do?
I would obviously examine, which looks like she has been examined and she's 2 centimeters dilated.
Yeah.
It's the abnormal CTG. You have a baseline of about 138 with reduced variability. At the end of the CTG, I don't know if that says if there is loss of contact or whether that's a deceleration.
It says loss of contact, correct.
I wouldn't put baby through labor. It's not a normal CTG. This baby is compensating with reduced variability and a baseline of 140. And she's 2 centimeters dilated, and she's a primate, and it's her third admission.
So the baseline before, we only have one auscultation from the presentation previous to this, and it was pretty much the same baseline. So we think that the baseline, starting baseline, which is normal for this baby, is about 35. So the baseline is definitely, hopefully within those few hours, is still the same for this baby. However, I completely agree that the variability is markedly reduced in this situation. Now, me personally, I wouldn't stop the CTG here, but I would want to continue it. But at the same time, I wouldn't have sent this patient home. However, I think she had the option and she was sent home, and because she wished to be sent home. But there's no further documentation to like who discussed it with her and what happened. So
Maya,
yeah.
I just want to point out as well the fact that we've not got a maternal pulse oximeter on, you know, like exactly like Pay said, it's very difficult here to determine whether or not it was maternal or not. So in order to turn it off at that I don't know, I can't remember if there's another slide where it's continued even further, but the fact that this has possibly been turned off at that point when we haven't actually identified if it's maternal pulse or not is also a bit of a issue?
So what I tried, I think the observations were done and they've been documented. However, it's a separate entry on CRS. It's not related to the CTG. So I completely agree. So my concern with this one is, first of all, we kind of like stop the CTG and I always kind of like never stop the CTG when you have loss of contact, because I've seen some really bad outcomes that happened afterwards. So this is number one. Number two, I'm quite concerned about this variability at this strip. So I wouldn't stop the CTG here either. And number three, I wouldn't send it home, and I've not documented the observation. So you're completely right. So I don't know what you think about what we have done with this strip. Would you have sent the patient home? Would you have wanted more observations? Would you have requested the CTG to continue further? And obviously, would you have sent the patient home? So I completely agree with you.
This patient needs admission. She needs to be on labour ward, not even hope ward. Never mind going home. And I think there is a difference between wanting to go home and counselling a patient regarding concerns with a CTG and your concerns on the fact that you think she needs to stay and be admitted into hospital. I think she needs to be on labour ward, to be honest. I don't even think this patient's suitable for hope ward.
I completely agree. And also, I wouldn't have sent her home the third time as well.
100%.
And can I also comment, please, on the decelerations happening here, which are very shallow and very slight and not easy to detect, but at the same time shows that the baby is showing signs of slight chemoreceptor even in that short strip here. Yeah, sometimes these ones are accompanied with meconium, but like we will see.
So I'm going to move to the next slide. We can see that it continues. Well done, Cara, because you've prepared it. You knew that it didn't stop there. Okay, so loss of contact, loss of contact, loss of contact, and then the baseline is stable. Maybe the variability is trying to get slightly improved, but I would still be concerned about that. And I can see that she's from the TOCO that she's contracting like 3 in 10. However, obviously clinical correlation is relevant. So came back in triage, third admission. I think it's fourth in this case. And 1820, she was examined and found to be still 2 centimeter, but fully effaced, mind you, before it was long cervix. The fetal heart rate is documented to be 134, and finally she's admitted to Hope Ward. And what do you want to comment about this CTG now, strip? This one is at 8 p.m. So after she's been admitted to Hope Ward. Do we have the same concerns, or are we happier? What do we think? So this lady shrunk at 2:30, primate, low risk at booking, hypothyroid, and now we're coming almost to 16 to 18 hours. The only thing that I could notice from the slide, Cara, that the pulse is 101. So initially, this is why I pointed it out before, that the pulse was around 88, and now it's getting higher and higher. So she's been examined and noticed that the cervix is effaced. But any concerns now? Are we still as worried as before, or are we happier a little bit? Are we happy to continue, or are we happy to keep her at Hope? What do we want? I don't want to pick on you, Peo, Cara, but I don't know who's in the room, so I can't ask Mr. Nagy because probably he will know it all. Who else is here?
The variability is increased slightly.
Okay.
Stable baseline.
Who's that?
Sorsha.
Sorsha, sorry.
Okay, Sorsha. Okay, yes, the variability is slightly improved. I completely agree. I mean, it's still at the very end, not that ideal variability that we would like, but it's slightly improved. Yes, I agree with that.
The pulse, would we think the pulse is pain related, or are we thinking because everything else is normal?
It could be. I mean, she received pethidine, but it could be pulse related. This is why hopefully later on we can put a pulse oximeter and monitor that, but it could be. But we have to also consider other causes of high pulse, but definitely it could be. There's no documentation about her being in distress because she has been offered pain relief options and she opted for pethidine. So yes, probably she is feeling the contractions more. She is more at distress and pain. So we've given her pethidine at 1940, and the decision was to examine her 4 hours later. So this is the strip now we are talking about to 2040, and the next examination would be 45 minutes past midnight.
Maya, so, in the
yes.
section, Deeba's put that this is a chronic hypoxia and that we should deliver, just to let you know.
Who said that, pardon?
In the comment section, Deeba's written a comment, chronic hypoxia, please deliver the baby.
Okay, and is that based on what? On the reduced variability, Deepa, or do you think that baseline would be changed before that, or is it only based on the variability?
Yeah, sorry, Maya, I just joined late. I'm just looking at the variability and it's not looking nice to me.
Exactly.
So it doesn't look very nice to me and it's going on for a long time, 4th admission. So I really don't know what the antenatal history is and how big and how small the baby is and how the baby is going to cope with the labor. So
with the labor. So this lady, she's para-not, BMI 31, and she has got a history of hypothyroidism. One incident of reduced fetal movement that I'm happy to dismiss because it was at 22 weeks. And she had a scan. Now, I don't know why the scan was done around 35 weeks, which showed normal growth lipo and Doppler. So normally grown baby, and just presented at term with SHROM. And she had a few presentations to triage with early labor, and she went back. The only thing that we've noticed from the beginning is that strip of CTG, which showed a baseline of 135 to 140, like the same as it has been. However, the variability was reduced. The only other factor that we've been keeping an eye on is that the pulse has been 88 and now it's 101. So Sorsha was saying, are we thinking of pain, or is there something else playing? However, the baseline, just to answer you with regards to the chronic hypoxia, has steadily been around 135 to 100, like 135 as it's here. So the baseline has been stable throughout. But I completely kind of see where you're thinking of the reduced variability, and this is chronic hypoxia. Anyone else thinks it's chronic hypoxia, or anyone else wants to comment on it? Are you happy to continue? Are you happy? What would you like to do?
No, I'm not happy to continue with this race. There's something not right with this race. So means, yeah, we need to deliver this baby. I just don't know. Yeah, that's what I would do.
Okay. Anyone else wants to continue? Anyone wants to deliver now? So anyway, with this case, she was offered to continue, and the next examination happened at 0045, as you can see, where she was 4 centimeter. I'm just going to show some CTG strips more to show you what happened. So this is the trace closer to the examination time. And I looked more, and this is like a small summary on the top of her progress. So she shrunk on the 25th, 230, 2 centimeters, 2 centimeter, and then 4 centimeter. And this is the examination just before the VE. Is everyone, I know that we said, some people said we're going to deliver. We can notice here that also they put a pulse oximeter, like a pulse monitoring, and we can see now that it's slightly, it varies just below that CTG baseline rate. But I agree the variability is reduced. They've given her Entinox, and she has been reviewed by the registrar, who's done a bedside ultrasound scan. On the scan, she was noted to have a very full bladder. So they said that we need to insert a urine catheter as the bladder was incredibly full. So also I've noted from the observations that her pulse at that point was 110, but it could be, as Sorsha said, related to pain, but it's slightly more than what I would like for pain. This is the next strip now. So we're talking about almost 2 a.m. after 2 hours after the last VE, sorry, 1 hour after the last VE. So this lady now is contracting around 4 in 10. The baseline remains stable. Anyone is happier about the variability?
Yes, in the previous slide, I noticed that the baseline had dropped to 120.
Yeah, exactly.
And like a cycling episode. And in this slide, we can see it's a much more wakeful episode, a lot more reassuring as well. Maternal pulse has come down, which has probably helped with the urine retention. Did they put a catheter in? They did, yeah, sorry.
Yeah, they did put a catheter in.
Helped.
And
yeah.
And then obviously the baseline, yes, slightly. When I looked at it, I thought, Sorsha, that maybe when that bladder has kind of been emptied, maybe there was a bit more of head compression causing a little bit more vagal influence over that trace. That was my understanding, because I was trying to figure out when they put the catheter, why did that baseline go slightly lower? But I don't know if Mr. Naguib agrees with that theory. Is that maybe when the head starts getting a little bit closer down, that you get kind of like pressure on the head and orbiter pressure, you get more vagal influence. So maybe that could be it. The other thing is that I agree that the variability is much improved. Yes, Mr. Naguib?
Tell me more. Why do you think the head compression when the bladder was full?
When the bladder was emptied, not when the bladder was full.
Oh, okay. So when it is emptied,
so I think there was like a liter in the bladder. So when you empty it, the head kind of falls down. So a bit more pressure on that head, not the other way around. You don't have to agree.
Yeah. No, it's possible, but for the head to be compressed so much, it needs to go like from -2, -3 into +1 in a very quick
manner.
Yeah.
Okay.
Which will not happen.
Not happen in this case. Yeah. Also from the pulse monitoring down below, you can see how the pulse is fluctuating with pain, which kind of confirms also Sorsha's observation, is that you can see the peaks with the contraction, which obviously can explain that this lady's in pain. Anyway, the registrar reviewed this lady and decided to put a catheter, IV access, take bloods. She was suspecting also a developing chorioamnionitis in this case, especially in view of the high pulse. And she's clearly documented that there were concerns regarding developing choreo. Now between 2 and 3 a.m., this is the CTG. The baseline now with IV hydration is settling around 125. Good variability, as I can see, with contractions. The case was discussed with the patient and the couple, and they explained that they have some concerns regarding developing choreo in view of the maternal pyrexia. However, the decision was to wait for the next VE before they decide on what type of pain relief they would like to choose and to make further decisions regarding management. Anyone wants to comment on this? It was picked up that they could notice accelerations that are coinciding with the contractions, and they felt it's a concerning feature. Anyone wants to comment on that? Would you be concerned on this strip of the CTG?
It looks potentially, you can see the maternal heart rate accelerating with the contractions. When you're worrying about accelerations with the fetal heart rate, you have to obviously determine that you're not picking up maternal, but it can be a sign of sort of central nervous system instability and signs of infection when you do have that. So I would potentially, obviously we've ruled out, we've got the pulse oximeter on, But I would obviously, that's another thing about choreo that I would be questioning as well. I haven't seen any pyrexia. I've only seen 36.5 as the temperature. Was there a temperature above this then?
No, there wasn't temperature at all throughout.
Oh, okay, fine. So what was the indication of choreo?
The maternal pulse.
Oh, okay, fine. Thank you.
Which I also would agree that I would think that choreo would develop, it would show first with maternal pulse and pyrexia as a late feature. But would you have been incredibly concerned over this strip? Would you want to wait more? What would you do? Are you happy to continue till the next examination?
Yeah, I would.
Yeah. Okay. So I think that we're happy to wait. Also, I think the accelerations with contractions could be a sign of partial cord compression. So you also think about them like decelerations or inverted decelerations, where the pressure is not significant or severe enough to cause complete occlusion of the cord. So you could look at it as partial cord compression as well. And this is the next strip. She continues to be contracting 4 in 10. The baseline remains at 120. The variability seems to slightly improved at the later part of the strip. However, also the maternal pulse is hovering around 120. And they're doing a fluid balance chart, and it says she's eating and drinking well. Thank you for that, Cara. Next strip between 4 a.m. and 4:50, her pulse is 125, and now the temperature slightly improved to 37. Septic screen was done, and they started IV antibiotics based on that. Anyone happy to continue, or are you happy to stop? I just need someone to comment on this.
It looks like the maternal pulse and the fetal heart rate is also very, very similar with the oximeter. When I look at the baseline, I think just looking at the previous one, I 100% agree with everything that Sorsha said. There was, yes, we had maternal tachycardia, but there was no signs of temperature. And also with the previous trace, I noticed 3 accelerations with the contractions, but otherwise there was other accelerations present without the contractions as well in between. But because normally when you have the accelerations, it's the ones that have acceleration with every single contraction. That wasn't really giving me that sort of trace. Looking at this trace, it looks like that the maternal pulse and the fetal heart rate is very, very similar. They're almost on the same line, basically.
Yeah, overlap.
Yeah. And you've got an increase in maternal pulse, and you said that they've done septic screening. And have they started the antibiotics?
They have started at 4:30. So literally at the end of the strip, they decided, because of the now the diagnosis is chorioamnionitis, they said we're going to do septic screening in view of the high pulse, and we're going to start IV antibiotics. I think the during on that night they were quite vigilant with using the bedside scan to look and differentiate the fetal heart from maternal heart. So they actually I think took that into consideration so that they can differentiate both, because it's documented that the bedside scanning, they scanned the patient in view of that. So I agree, they must have picked up on that, and they managed to differentiate that this is actually maternal pulse and not fetal.
Did we consider FSC, the use of FSC at all?
There's no documentation of that, I'm afraid.
Okay, thank you.
Yeah. So I'm going to move next. So VE at 440 by the registrar, she was still 4 centimeter. And in view of the fact that she's not progressed even though she had decent contractions for the past 4 hours, the decision was for emergency cesarean section for choreo in view of maternal tachycardia and lack of progress. She's been given pre-meds and had cesarean section. So I just want now to discuss what you think Would you have sectioned her at that stage? And what would you think the outcome of that baby is?
I would have 100% sectioned.
Okay.
I would have sectioned her as well at this time of not before. I wasn't too much like worried about the CTG too much, but in view of the nearly 8 hours, 10 hours, we are 4 centimeter. We are not progressing. It's either we think about the baby and the mother and the labor, and we cannot do cento. So this is the right answer. Yeah.
Yeah, exactly. She was contracting 4 to 5 and 10, documented good contractions, and she had I think 24 hours of SHROM now with maternal pyrexia. So all of the indicators pointing towards choreo. Now, what do we think is the baby doing now? Shall we do the Apgar game? Just shout out what you think this baby has done and what the gases could be.
You've caught the baby at quite a good time, so I think gases will be fairly normal, and I think Apgars will be quite normal.
Okay, thank you, Sorsha. Anyone else?
I'm not going to ruin it because I know what the gases
And no,
are.
you're not going to ruin it. You've done this presentation, Cara. So no, don't ruin it. you don't get to play the game, Cara.
No, I know.
No.
You have to do one next time, Maya, and then I can actually join
Faye.
in. But I just wanted to sort of note that obviously we will be moving to a much more physiological approach in the next sort of year or so, where FIGO isn't necessarily our main use of classifying CTG traces. And I think it's so important that we've mentioned this a lot, that is this baby fit for labour? And obviously she's got herself into labour, but in terms of helping her to progress with that amount of contractions and not being able to do anything about it, then I think this was our alternative and our option going forwards.
Mm-hmm. So I think we all agree that the section decision was justifiable. She had enough indicators to developing choreo. We were concerned throughout at certain points. The accelerations could be not due to choreo, but at the same time the mom was telling us that this baby's choreo. So I'm going to go straight to that slide. So this is the theatre CTG. The baseline slightly increased to 140, and then Apgar 8, 9, 10. Now the gases, I was actually quite shocked with this gases. I didn't think it would be 7.0, but we could have had added elements acutely during preparing her for the section. But 7.0 arterial and venous 7.11, and the baby was actually transferred to SCABU from theatre for respiratory distress. The high baseline basic CES is 12.0, means the baby was buffering for a long period of time. So I think it was a justifiable. I don't know. Anyone else can comment? Mr. Nagy, please help.
No, I completely agree. I wouldn't have sectioned her earlier. I would have given her the chance in case she is progressing with her own contractions. And at the same time, this time of the morning, credit to the registrar, didn't wait another 4 hours, didn't like intervention in a timely manner, and with a good chance for labor. So nothing to add, really.
Nothing to add. And I think the baby has confirmed that, you know, the things developing. I would have wished in this case that they would have sent, Cara, do you know if they sent a placental swab?
I'm not sure if they sent a swab, but I know that they sent the and I know that they didn't send the placenta, but I'm not sure about the swab. But
the swab, because it would have been interesting to kind of see what it showed. Yeah. And the baby was admitted actually to SCABU, so I think it's definitely confirms retrospectively that we were talking about choreo. So you know, good management in this one in a timely manner. There was no superimposed hypoxia. So I'm going to take the opportunity, just because I'm talking today, I'm going to show you this thing. I don't know if you have to kind of maximize your screen, or you can see, this is a poster actually I've done a couple of years ago from histology sent to St. George's, and this is how I got to know that each placenta costs 350 quid just to be analysed by the histopathologist, because the aim then was to kind of try to figure out if we can identify chorea on CTG, and then look retrospectively from those placentas which confirmed actually chorioamnionitis, and see if we can pick up some features that we can say from now on we can actually rely on it as a method of detecting chorioamnionitis. So this was a poster that I presented in Portugal actually a couple of years ago, just in the midst of COVID. So the placentas were sent from Kingston, and it was over a few months, and then we tried to look at the features. I'm just going to jump straight to the conclusion. So 70 placentas were actually sent when we suspected on CTG chorioamnionitis. So we were trying to find out features that we can look and say, this baby has got choreo, we're going to deliver based on choreo, no superimposed hypoxia, and then we're going to analyze the placentas and then see if we were right. And actually a good number out of those 70 cases, 64 cases did confirm chorioamnionitis with various stages of choreo, from early choreo to phalangitis. And I will maybe hopefully soon just kind of talk about the histological classification of that. This is just a kind of like a quick summary of what it was. And actually, we can now, I think, rely on the baseline rise without preceding deceleration, because in this small cohort of placentas, it shows that 82.8% of those confirmed cases did actually show baseline rise without preceding decelerations. So it is a good percentage that we can rely on. However, the other thing which I think is also very good is the lack of cycling, whether it's with reduced variability or with maintained variability, which means that you will find that this trace is not actually cycling. It's just like a steady state. So no periods of much reduced and no periods of much increase. So it's just like literally a steady state. And in some features, we could pick up the zigzagging and the sinusoidal pattern and the overshoot. So I know I've put here only a very, very small thing, but when you see this kind of like short, repetitive saltatory pattern, this is what we call the zigzagging. And it could be a feature actually of chorioamnionitis. And I know in this case we said accelerations with contractions. However, obviously loss of accelerations can always be point to a baby in distress. Overshoot was also a very important features that we could see as well. So this is just a quick summary. I'm happy to send it to everyone and circulate it. It was done 2 years ago, and then following that, they expanded on this initial cohort of cases, and they expanded it to 200 cases, and we managed to get another poster in the following year. But I will leave that for a different talk, but I just thought if anyone is interested, this is what we've done. So yeah, good, well-managed case. So thank you for whoever's done that, and thank you for Cara for presenting this case, for preparing this case.
Thank you, Maya.
No, thank you. Any question?
Thanks, Maya.
Thanks, Faye.
Thank you.
Thank you. All right.
Guys, can we
Thank you.
also remember to send placentas and swab them? This is very important.
Yeah, well, definitely. I think we said last time that we're going to hopefully work on the guideline or short kind of protocol to sending the placentas.
Yeah, that's the plan in the next couple of months.
That's the plan.
Yeah.
Okay. Thank you, everyone. See you next week.
Thank you very much, Maya.
Thank
Thank you.
See you.
Bye.